Good afternoon, everyone. My name is Daphne Steriatis, and I'm a Senior Associate with CAQH Core. We are excited to have you join us for the fifth installment of a webinar series with Core and X12, where we'll be discussing the 270-271 transaction standard and operating rules. You can access the webinar materials by downloading the presentation slides now from the handout section on the right of your GoToWebinar menu. You'll also be able to download the presentation slides and recording on our website after the webinar. Finally, all slides and recordings will be emailed to participants the next 1 to 2 business days. If you have any questions, please submit them at any time using the questions panel on the GoToWebinar dashboard. I want to thank all 3 of our speakers for joining us today. We have Donna Campbell from Blue Cross Blue Shield, Illinois, Everett Ford joining us from Optum, and Aaron Weber from CAQH Core. With that, I will, session outline first. We'll start off with an introduction to the 270-271 standard, and we'll hear from Everett and Donna, and then we'll turn things over to Aaron and hear more about the operating rules, and then we'll finish things off with a Q&A session. So with that, I'll pass things on to Aaron for an overview of the eligibility transaction.
Thanks, Daphne, and I think we need to put the slides up for everyone as well. But today's session is really an introduction to the eligibility and benefit inquiry and response transaction. For those of you, many in the industry have been using this transaction for quite a while now, but there may be some of you that are new to this transaction. So this webinar is in particular a good place to start and ask questions. Some quick background for the group is that the eligibility and benefits verification is when a provider inquires to a health plan or from one health plan to another to get eligibility, coverage, or benefits associated with the plan. And then a response, the 271, is delivered from the health plan to the provider. This transaction is a HIPAA mandated transaction for eligibility and benefits, and version 5010 was adopted in 2009. And then in 2013, HIPAA-covered entities were also required to comply with federally mandated operating rules for eligibility and benefits for a health plan. And we'll walk through a number of those requirements today. The eligibility and benefits transaction is one of the most highly utilized transactions in the industry. Right now, about 89%, almost 90% of eligibility and benefits transactions are conducted electronically using the X12 transaction. However, it is interesting to note that the greatest opportunity savings for the industry, or one of the greatest opportunity savings as identified in the CAQH index, is getting that last 11% of eligibility transactions electronic, because the volume of transactions is so high across the industry that that 11% increase would make a significant difference financially across the industry. So with that, I'm going to turn it over to our colleagues at X12 to share a little bit about what's happening in X12 and talk about this important transaction. Donna?
Sure. So my name is Donna Campbell, as Aaron mentioned, and Daphne. I am a provider portal and provider connectivity product manager at Blue Cross Blue Shield of Illinois. My health plan is part of the HCSC umbrella, which means we're part of Texas, Oklahoma, New Mexico, and Montana, in addition to our Illinois presence. I have been a co-chair of the X12N, which is for insurance, Task Group B, which is our business task group, Work Group 1, which is the eligibility and benefit transaction work group, for a number of years. I think my first year that I was elected was around 2002, and have made my presence very well seen and heard over the course of the last 20 years, from when 4010 was mandated to when we built out 4050, then mandated 5010, we built out 6020, we've built out 7030, and now we're on our next versions. And so I've been through the many iterations of the 270, 271 development for the number of years representing myself in my organization as a health plan, as well as putting my facilitator hat on at X12 representing organizations as a whole to make sure that there is consensus and due process for that transaction. So the next slide, we always at X12 have to remind folks that this is a presentation. It's for informational purposes only, and the content is naturally point in time information. So anytime we have corrections or additions or modifications of any sort, we would do that behind the scenes and republish or re-present if we need to. I'm going to go quickly over the general about X12 background, the transaction, the eligibility and benefit transaction, such as the purpose and scope, the benefits of the usability of the 270, 271, what are our typical users or stakeholders in the 270, 271 eligibility and benefit arena, and a simple use case or workflow that most probably already know, but just to summarize what the 270, 271 typical workflow is. And then we'll do a wrap up and turn it over to our CAQH partners. So the gist of the X12 arena is each transaction that is HIPAA mandated, as well as a large number of transactions that are outside of the HIPAA, the conglomerate or sets. There are subcommittees, and as I mentioned earlier, we're part of the insurance subcommittee, and then there are task groups within those subcommittees, and the insurance subcommittee has at least 3 task groups. There's a few other work group or task groups that surround our X12 task groups. We have an A, which is more of a project management task group, a B, which is the business task group, and a C, which is the solutions task group. And in the B task group, which is where my work group falls, there are a number of other transaction work groups that are in there, like the claim, the enrollment, claim payment, claim attachment, claim status, prior authorization or services review. And then with each of those work groups, we have a number of transaction or TR3s, books, we call them in our native language, that we're responsible for creating the business rules and coming up with the business solutions from a business standpoint, and then turning them over to our solution task group that will then build out the physical solution that you see within the 270 or the 278 or the 837, etc. So today we're going to go over the X12 TGB, X12N TGB Workgroup 1, 270, 271 eligibility and benefit transaction. Just a little background again, X12 is consensus based, so most people know consensus as being, 100% of the people agree. We have certain requirements that say that due process and a majority rules follow our guiding principles. So we would follow Robert's Rules of Order, and we're accredited. So we're ANSI accredited through the National Standards Developer, and we do ongoing maintenance of all of our transactions, regardless of whether it's a HIPAA or administrative simplification mandate. We still build out the data and the format and the business solutions based on industry input, and then we look at harmonization and commonality across the transactions to make sure that we don't disadvantage another transaction by introducing change to one of the transactions. We have, for many years, obviously since 2010, had very, very reliable and efficient, effective, and I would say high volume interest and just transaction in general. The volume of transactions that float through the industry since 2010 was mandated back in 2002 is enormous. My organization alone supports around 1.5 million eligibility and benefit transactions a day, and that is obviously a drop in the bucket compared to the industry. But because we have ongoing and ever moving industry development, we know that each time that we have a hiccup or an obstacle or a roadblock with the transaction, that there are vehicles and ways for us to introduce or request change through the X12 process. And that is how the development of what you see today and what you'll see tomorrow when it comes to the newer versions, whether mandated or not, come to fruition. All of X12, again, there's not just the insurance subcommittee, there's a supply or a materials management, there's transportation, there's a task group that's called technical assessment. There are several subcommittees that oversee the different areas of transaction exchange. So we have finance, government, insurance, supply chain, transportation, and then the technical assessment that all put some time and energy into developing new transactions so people can support the everyday EDI needs of whatever industry it would pertain to. An idea here is X12F, for example, the finance subcommittee. They have transactions that span a true banking industry, but they also have transactions that span our healthcare industry. So we have overlap there, and that's why you can see that it's a very heavily engaged, heavily involved set of practices that require due process and require consensus to make sure that each group represents the needs accordingly, but also satisfies the industry from a need as well. The next slide, please. So we have a handful of staff. X12 has paid staff that help arrange and coordinate and manage the everyday process. And then we have a huge number, hundreds of volunteers that come together 3 times a year in person. Hopefully that will be ongoing. And then in the background, when COVID hit, we did so in a hybrid setting. We meet 3 times a year formally, but then each of our work groups meets anywhere between weekly or monthly, and we get together as our standard work group members to discuss any maintenance requests, any requests for interpretations, any activities that X12 has prioritized for each of the work groups. We get together and we work on those solutions or those business needs as a team. We are made up of corporations such as myself or Optum, associations such as the American Hospital Association, American Medical Association, we have the Blue Cross Blue Shield Association, and then we have organizations like CAQH. We have government entities that participate, such as CMS and HHS, and then we have individual representatives that pay for a different type of membership, but they have all the same access and all the same inclusiveness as any other paying member. Our standards are the backbone to everything that we do. There's 2 different levels of work that we do. We build out standards, and I like to consider the standards for those who are back in the day COBOL oriented. I like to arrange that conversation such as standards are like the copybook, and then the transaction is the actual code that pulls in the data from the copybook. And another way I'd put it is standards are like the template for a book where you have a foreword and you have a bunch of chapters, and then you might have something at the end that does you're paying homage to where you've taken the material from. Well, the standards are the same way. It is the template for the book, and then each of the chapters is the TR3 to say how the book should be built out and what is in the book, what's the content within the book, what is the equivalent of our TR3s. So we build out these books to represent and to support our business-to-business exchanges, and that would be anything. In the case of the 270, 271, it could be how does the 270 come to a plan, and how does the 271 go back to the submitter of the 270. And then we have standards that are based on just in general our intellectual property. So there may be schemas that are separate and apart from the TR3s. We also have other I'd call them categories of support, which are our external code lists that we support within X12. And then we also, or should I say the Registered Standard Committee. And then we also have relationships to other standard and code supporting arenas such as HL7. If we want to go to the next slide. So again, I mentioned how a large number of transactions are supported every single day. And just in the 270, 271 spaces, Erin pointed out, 90% of our transactions are done electronically, but there are a host of other transactions that float through all of the different industries and organization types. And those transactions are your typical transactions. A lot of people like to use the example of when you go to a cash station or an ATM, or I think some folks used to call it a Mac money machine. They would have to talk to your bank. So there are transactions that are happening behind the scenes that are going between that unit that's in a parking lot at a banking organization that has to talk to the bank system to make sure that you have money in there, that you're the person authorized to take the money, and then remove the money from your account if you're getting a cash advance, etc. All of that's done via EDI, and some of those transactions are actually built out by X12. So you can see a number of our everyday handling of any kind of activity that you do right during the day. You go to a store and you buy something off the shelf, you buy a 6-pack of Diet Pepsi. That 6-pack has to be pulled from their inventory. That's done by EDI. That's done by an X12 transaction. When they have to repurchase more 6-packs for that store's shelves, they have to do that through, or calling Pepsi or calling 7-Up or whoever it is and have that 6-pack reordered. That's all done with EDI. So you can imagine how many healthcare transactions are there. Multiply that by the number of actual EDI transactions that are in the world, basically, that are doing things that every single day we support. We have a bunch of different entities that support the EDI transactions, specifically our 270 and the claim transactions that are huge in the industry. A lot of those organizations aren't just in the United States. They're in Canada, they're in Mexico, they're across the world. And those transactions are how those questions and answers, in some cases, the requests and the responses, that's how they get the information shared. It is in itself interoperability. It's just in EDI in the X12 format, maybe not in other formats that are newer to the industry, but it is proven and it's been well established for a number of years, many years before my involvement, but a number of years since, I believe, 3010, 3070, those are the two major transaction sets that were done before 4010 was mandated. This is the evolution of the transaction, and the building out comes from the industry inputs that we as industry members bring to X12 to request change. So as we move to the next slide, this is how X12 is structured. We have a board of directors. They're elected, and then we have X12 member representatives, which is myself, Everett, Erin, our X12N leadership. Those are broken down into two different subsets of groupings. We have the ASC, which is all of the work that's done within the transaction. So I mentioned X12C, X12F, X12I. Those are our supply chain, our materials management, our finance, our tasks, and our insurance. Then we have a procedures review board to make sure everybody's following due process. And then we have a policies and procedures group that oversees all of the policies that we adhere to and all of the procedures that support those policies. Then we have the RSC side, which is essentially the groups that do business above and beyond and outside of the everyday work group activity, but it spans each of those X groups on the left. So our parliamentary process group, our ICE group, our ECHO group, and our business group that does all the business across the board, the business to everything, which is the X. These are groups that support everything. Everything on the right supports everything on the left, but not necessarily everything on the left is driven by everything on the right. So there's a relationship there. But again, parliamentary, for example, Robert's Rules of Order, we have to do that in each of those organizations on the left. So anytime there's a change or a way we want to handle the way we do our everyday agreements, we follow our parliamentary X12 group, and the ECO, the ECHO we call it, those are our external code organization oversight groups. So they are the ones that help us build out the external code sets that are within the purview of the TR3s. And the all of these groups, these are thousands strong that we have. This is where we build out those transactions on a day-to-day basis. Next slide, please. So most of the people know about the American or the Accredited Standard Committee. This is the group that creates those implementation guides. Those are the ones that we most frequently refer to as HIPAA guides, but there are a lot more than just the HIPAA guides. As I mentioned, there's claim attachment, there's requests for additional information under different of the transaction sets, there's the acknowledgement transactions. Each of those are handled by those ASC X12N work groups or F work groups or the government work groups, etc. We also have the other side, which is the Registered Standard Committee. Those are the groups like the ECHO, like the parliamentary. They basically build out stuff that crosses every line on the left-hand side. So they come up with our word books to harmonize our vocabulary across the guides. They build out our resources on the X12 site. They help with formal and informal planning for transaction evolution, such as when we bring it to the board of directors and say we want to move some of the transactions forward to the next iteration of HIPAA adoption, et cetera, et cetera. So those two groups, they work independently of each other, but they have to work in an integrated fashion to move forward through the process. Next slide, please. So our library, which we talked about, we have the standards, which most people are probably less familiar with. Then we have the technical reports. We have tier 3s and tier 4s and tier 2s. Those are different types of technical reports. The tier 2s are often a companion-like technical report to the tier 3s, and they help build out different rules for how to implement the tier 3s that can go through a much faster process of development and can be done outside of the development of the standards. And the tier 3s are what are building on top of the standards. We have the external code lists, like we mentioned, where you have certain codes that are referred to in the implementation guides or the tier 3s, but they're externally managed and updated. We have schemas that are also built on the standards and the implementation guides that represent the same data that would be in the tier 3s, but they don't necessarily have the structural expectation that's in the TR3. And then we also have other consultative or other specific offerings to help implementers. And a lot of that still falls, and much of you are probably very familiar with it, but RFIs are a great example. We have a way to build out requests for interpretations for existing adopted or existing published guides that may need some clarification from X12 to help implementers understand whether or not something is done this way or done that way. And there's two types of those RFIs. There's formal and informal. And those have different definitions and different workflows, but at the end of the day, they're both to assist when the implementation guides may be challenging to understand. They help the industry participants and the members of the industry, not necessarily members of X12, get clarification from X12 and the subject matter experts at X12 to help those implementers implement or move past any obstacle. Next slide, please. So X12 approach, we talk about this a lot. We are very consensus driven. We follow due process, as I mentioned. We're very open-minded. We let anyone and everyone who comes to our meetings, whether they be virtual or interim or in person, speak and provide commentary. Because we are due process and consensus driven, a lot of what we do is done through voting, and our voting is done electronically. We always have the obligation, first and foremost, to build out our TR3s to meet the business needs of the industries. So we need to make sure that when we have a need for change, that we're getting those changes pushed through from the individuals or organizations that need the change, and then we need to, I'm going to use the word harmonize again, harmonize those changes to make sure that they don't negatively impact some other industry or other organization that that change may address or impact. So we try to collaborate. We do so in many ways, again, through interim conference calls with all of the work groups, through our face-to-face meetings, and then we have outreach meetings such as like this, where we have webinars where we try to enlist the support of the industry that may not necessarily be at the table with us at these standing meetings or these in-person meetings or necessarily member organizations yet, but we want to open the doors to let you know how things can get in and how we can help change the industry and advise how that can be done. So now we'll get into the eligibility and benefits transaction. This will be quite simple, so I probably will only spend a few minutes discussing it. First, I want to talk about the purpose and scope of the what I call E&B transaction. Right now, currently, the mandated version under HIPAA is the 5010 X279A1. That version and any version after that, their sole purpose is to define the requirements and give guidance on how to exchange the 270, which is the request or the inquiry, and the 271, which is the reply or the response. The transactions give you an indication of requirements and then optional or situational segments and elements that define when that situation is present, what must be returned, and when. The transaction is paired. A lot of people have asked in the past, can you do one or the other? In this particular version, it's a request and response transaction, so it must be a paired transaction set that goes one with the other. And it is basically covering the responsibility of the transaction is to advise the requester or the submitter of the 270 the coverage, the eligibility, and the benefit information on a member, which at that point in time is likely a patient, namely a subscriber or a dependent in a health system. Next slide, please. So the high-level benefits of the 270, 271 are, some are obvious, some have been addressed with operating rules more cohesively, which are, it supports exchanges that are both in real time and in batch, and then defines what is considered real time and what is considered batch in the case of 5010. It supports a variety of stakeholders, as we met earlier, a lot of users or stakeholders, as we call them. There are payers, there's providers, there's vendors, and there's clearinghouses. And vendors and clearinghouses might be one and the same in some arenas, and then they could be separate and distinct in others. The transaction itself is how you reflect or you respond to an inquiry about a member or members, and you give a point in time response depending on the information on the request as to the memberships of the member themselves, whether they're active or inactive, what level of active they are. Are they active with an update coming into the system? Are they active but maybe they're in a grace period and that grace period is set to expire soon? And then there's also coverage that explains, what type of coverage do they have? Do they have PPO coverage? Do they have HMO coverage? Do they have major medical coverage? Do they have dental coverage? And then there's also other coverage levels such as family or employee and spouse or employee only levels of coverage. It sets the basic requirements to define how the requests should be set up from a data and a format standpoint when you're talking strictly the structural 270, and then what the 271 should and must contain to help the payer or the provider, the vendor or the clearinghouse with the next step in the workflow. Often that 270, 271 exchange is what is used to avoid the need for a phone call from a provider to a payer to determine the coverage. And with the operating rules in 2013 and the 270, 271, 5010 transaction base, those two require a larger subset of granular details than, say, the original 4010 did. And that helps understand other needs that could be a phone call cause, which are if there's a primary care physician that's involved, if there's a particular kind of prior authorization requirement that's involved, is there another payer that needs to be engaged to determine a coverage or benefit level. Those are other capabilities that the 270, 271 can support that may or may not necessarily be in an every use case scenario, but are above and beyond the bare minimum requirements of the TR3 and in support of the everyday exchange between the stakeholders. Next slide, please. So we mentioned who are the players or the stakeholders. So we're going to highlight just in a little more fashion here. Providers who need to determine the eligibility status or even coverage or benefit status on their patients. Providers who need to know whether or not a prior auth requirement exists for a particular service or benefit. You need vendors who potentially are in the middle. They're not payers, they're not providers, but they may be offering some carve out that may need some coverage details, such as in the case of telemedicine or telehealth, where they're determining if a member has the capability for virtual visits or telehealth, even though they may not be a provider, they might be the provider of the providers that would offer that service, and first must figure out if that member has the capability to receive telehealth, for example, before they would allow a telehealth provider to provide that service or treatment virtually. Vendors who are verifying coverage for COB purposes. CAQH actually is one of those organizations that we have also dubbed as a vendor in some cases, because they do something called COB Smart, which is where they're playing the role of helping marry the different payer organizations to see if there's overlap in coverage. And so in that case, they're neither a provider nor a payer, but they are obtaining details about membership and coverages to alleviate potential money that's lost in the industry for lack of awareness of COB. Payers who need to verify prior coverage with previous payers for continuity of coverage. A lot of folks know in the interoperability world with some of the newer HL7 standards that there is continuity of coverage with the clinical data exchange transactions or FHIR exchanges, but the 270, 271 has been able to do that for years because the 270, 271 can support payer-to-payer exchanges, provider-to-provider exchanges, vendor-to-vendor exchanges. It all depends on the context of the business need and how you create and structure the transaction on what level of support could be required. We also, in the 270, 271, support the responses of those payers to whatever and whichever request is received. So if it's a payer to payer or a provider to payer or a vendor to payer, the payers who are the official recipients of the 270, those are the payers that are the official information source, and they would return the data. Clearinghouses who are kind of playing the in-between role, where they might be massaging the structure, they might be taking it from portals, they might be taking it from practice management software, and because they're a one-stop shop, they're able to connect to multiple payers with only one designated point of reference from the multiple providers. So they kind of play the tollway in a way, and they're the gatekeeper of a lot of that provider to payer exchange. Next slide, please. This is my last slide. The overview of a typical exchange. We try to be a little less formal with the way the words are in here, because there's a lot of confusion in the industry on what's an information receiver, what's an information source, who's a submitter, who's a receiver. So in this case, we tried to simplify it just in a general workflow, which is the submitter of a 270, often referred to as the information receiver, identifies the information source, who is the payer or the other entity they're sending the 270 to ultimately, and they will identify that information source to figure out what answer that they're looking for in the question that's on the 270. That receiver, who is often referred to as the information source, validates that submitter's authority to make sure that they're allowed to give them information, much in the confines of privacy. That receiver will search for the subscriber dependent that was in the subscriber or dependent area of the 270 and determine that eligibility or coverage status of that subscriber and dependent. The receiver will use some of the information, like the data service that came in on the 270, potentially the service type or procedure code, the NPI of the provider that might be looking for information. If there's any diagnosis information that they support and or place of service information, they'll use that information to generate what response they want to return on the 271, and then may include that same information to help tailor that response to that information receiver or that provider that submitted the 270. Then in the case of the receiver, AKA the information source, when they generate the 271, they have to generate it within the confines of the requirements that are in the TR3. And the TR3 has requirements both in the front matter, which is the forward, so to speak, if you're thinking about a book, as well as the structure or the tables, which is the chapter 1 through chapter X, that define the actual structural format of the transactions, the elements that make up segments, the segments that make up loops, and then all the data within. And that is where my bit ends. Everett, do you have anything to add?
Just real quick, a quick introduction. I work for Optum. I support a software package that does validation of X12 transactions. I spent several years doing customer support, so I have a fairly broad perspective. I would even call it the perspective of a generalist in approaching this, in that I deal with, in my day-to-day job, I deal with all transactions. I deal with, I've worked in a clearinghouse environment. I work for a payer. I also have done direct customer support, so I've dealt with vendors, and I've dealt with providers. I've dealt with probably every type of person that uses the software. As well as that, I have a fairly strong validation perspective, and when there are changes that take place, I look for helping make sure that it's easy to validate and find problems in how it produces it. And lastly, I thank you for a great presentation.
Thanks. So in short, you know, obviously I've gone through what the business purpose is or purpose and scope of the 270, 271, level set some of the general benefits, not to be confused with the service type code 60, inside joke, of the 270, 271, the different users and the workflow. What this transaction can do for the industry, as I mentioned, is a very, very high use, high touch point, high visible and heavily used transaction that can alleviate phone calls. But the only way that we can move forward with addressing any gaps or obstacles that may exist with the current version is to introduce change through new versions, and that change has to come from the industry. So it is imperative that we have participation, whether you're an X12 member or not, through CAQH, through WEDI, through X12, to participate in the building of those change requests and those maintenance requests to bring forward some of the industry needs to make sure that we progressively move the transaction from here to there in a methodical, swift, but quality way. Thank you.
Great, thanks, Donna. That was a great overview of the work that X12 is doing and the eligibility transaction itself. I'm Erin Weber, again, Vice President of CAQH Core, and I'm going to share some background on CAQH Core, how we work, and also the eligibility and benefit operating rules and how those align with the standard. Many of you know that CORE is an industry-led, multi-stakeholder group of about 100 organizations that come together to develop operating rules or business rules that sit on top of the standards. They drive interoperability and create more consistent data exchange across the industry. We were designated by the Department of Health and Human Services as the National Operating Rule author under HIPAA a few years ago. So several sets of our operating rules, including the eligibility and benefit operating rules, are federally mandated. Just to highlight some of our collaboration with the SDOs, the SDOs do serve as advisors on the CAQH core board, so it's helpful to have that input at that strategic level of our work as well. We see our role not only to convene the industry through our subgroups and work groups to develop and vet and update operating rule requirements, but also to deploy and drive adoption through our certification program, through our education and outreach efforts such as these, as well as measuring the impact of the operating rules through our pilot and measurement initiatives. On the next slide, you can see a list of our participating organizations. It's really an impressive representation of all the stakeholders that are impacted by these operating rules and standards, and we could not do our work without their input. As Donna said, this work is really truly industry driven, so we need to hear from you and your experience to ensure that the operating rules meet the needs of the industry. So what are operating rules? On the next slide, the definition of operating rules is included in the Affordable Care Act, and they are the necessary business rules and guidelines for the electronic exchange of information that are not defined by a standard or its implementation specifications. So operating rules really facilitate interoperability by building on the standards and ensuring benefits for each stakeholder group. And that's why having multiple stakeholders involved in the rule development process is critical. The rules complement and support healthcare industry and other standards. For example, our connectivity standards are very industry neutral. They never repeat or conflict with the information that is in the standard. So, for example, when the industry moved from version 4010 to 5010, any requirements that were previously in the operating rules that were included in the 5010 version of eligibility and benefits were then removed from the operating rules to ensure we were meeting the definition of operating rules. Operating rules are used in many different industries, including financial services. We worked closely with NACHA, the Financial Services Operating Rule Authoring Organization, to develop our EFT and ERA operating rules around the payment and remittance transactions. On the next slide, I want to highlight we have 8 sets of operating rules available for industry implementation, and they really support the true spectrum of the healthcare revenue cycle, beginning from when a patient schedules an appointment and that eligibility and benefits needs to be verified, all the way through that payment and remittance process. Within the eligibility and benefits operating rule sets, there are 4 operating rules. There is an infrastructure rule, a data content rule, a new rule created in 2020 to share patient attribution information to support value-based payment arrangements, as well as connectivity rules to create consistent means of exchanging this data. On the next slide, we define infrastructure and data content operating rules, and these are really the 2 types of operating rules that exist in the industry. Infrastructure rules can apply across transactions. They're really established basic expectations on how the data exchange system works. So if you think about things like response time, connectivity, these requirements could be used with any version of a standard and could even apply across different standards for the similar functions. Data content rules support the exchange of data and allow stakeholders to access information they need to manage an identified process. So they really enhance the requirements within the standards and build on that. These rules can address ongoing maintenance, and many of these rules have ongoing maintenance and set expectations for evolution over time. And the rules really support further use of the base standards whenever possible. So on the next slide, I want to highlight some of the requirements within the eligibility and benefits operating rules. The first are the infrastructure requirements. So when we think about infrastructure, we're thinking about how and when that transaction is exchanged. So there are connectivity requirements. There is a safe harbor requirement for health plans and providers and vendors to support common connectivity methods so that it is known that there is a single way that everyone can support and exchange the eligibility transaction and other transactions. There are requirements for acknowledgements. These requirements are not federally mandated because we don't have a mandated acknowledgement standard, but they are required for the core certification program. And I should have mentioned that a little bit more upfront. Organizations can become core certified in any of our operating rule sets, and that's just demonstrating conformance with those requirements through a certified testing program. There are response time requirements, both for real-time and batch, and the operating rules actually require organizations to support real-time eligibility transactions, and that is part of the mandated operating rule requirements. And that requirement really improved providers' ability to, for example, collect at the time of service rather than sending patient bills, days after a visit. There are system availability requirements, and that's a requirement that the industry just updated over the past year for the amount of time that health plans need to have their eligibility systems up and running so that they can get a response in a timely manner. And then a similar companion guide flow and format requirement so that regardless of the health plan a provider might be working with, the same information appears in the same place for a companion guide to support the eligibility and benefits transaction. Then within the data content operating rule, there are really three overarching requirement types. The first is related to patient financial and benefit information, normalizing patient last name, and error code reporting. And I'm going to get into more detail on these on the next slide. And then the final operating rule that I mentioned is that single patient attribution data content rule. And that rule requires health plans to send back the explicit attribution status of a patient. Is it yes or no, this patient is attributed or partially attributed to the provider? What are the effective dates of that attributions? And there are then requirements for the receivers of that transaction, typically a vendor, to display that attribution information so it can be used in an actionable way by the provider. Again, that last rule is not federally mandated. It is available for voluntary industry implementation. So on slide 32, I want to take a deeper dive into the data content requirements of the eligibility and benefit operating rules, because in particular, these rules, and Donna played a key role co-chairing our subgroup to update these operating rules. They were initially developed, they were the first set of rules, in fact, that were developed by the CAQH core participants. And over time, there were several emerging business needs that were identified and needed to be addressed. And so that resulted in the update of the rules. But the federally mandated eligibility and benefit rules require that, in particular, plans return key patient financial information, including co-insurance, co-payment, base and remaining deductibles, any in and out of network variances, and the name of the health plan covering the individuals. This is really important information, again, for patients to have at the time of service. They also require the return of 52 specific service type codes so that providers can receive more explicit eligibility and benefits data. And then with that normalizing patient last name requirement, thinking about ensuring health plans and providers can uniquely identify patients using some of the requirements defined in that section of the rule. The rule also defines a standard way for plans to report error codes so that that is consistent across the health plans a provider might be working with. And then vendors, particularly provider vendors, must be able to detect and extract some of these data elements to ensure that the provider can use them in a meaningful way. So as I mentioned, over this past last year, the core participants worked together to update the eligibility and benefits data content rule, and that was approved in early this year with 88% support across the board. Those requirements and those updates really got to some of the biggest challenges that organizations are facing today. The first requirement that was updated related to telemedicine and required the use of specific codes to indicate what service or benefit is available for telemedicine. Now, in the era of COVID, having that information in the eligibility transaction is critical. It also added 71 new discretionary service type codes and 55 new mandatory service type codes to that list of codes for a total of 178 core required service type codes. A required plans to support the communication of the number of remaining visits or services left on a benefit, enhances requirements to respond to eligibility and benefit requests at the procedure level for physical therapy, occupational therapy, surgery, and imaging. This was an area of significant need across the industry. The requirements also require communication if a prior authorization or certification is required for a core required service or procedure. And then it also provides more granular level data for members of tiered benefit plans and communicates tiered network status of in-network, out-of-network, or exclusive preferred for the inquiring provider. So a lot more robust detail with these 2022 data content rule updates that are meeting the needs of the industry today. Next slide, please. As I mentioned, those requirements, that update will be required for implementation by core certified organizations as they go through the recertification process beginning in 2024, I believe. Organizations have a couple of years to prepare for those updated requirements. As we look to what comes next, I want to put out a little bit of a call to action here. CORE is continually conducting and working with the industry to conduct ongoing pilot and ROI assessments. So if your organization is potentially recertifying in some of these newer requirements or looking to implement new operating rules, we do want to work with you and help measure the impact of that. To that end, we encourage you to become core certified, particularly on some of these federally mandated operating rule sets where we know CMS is conducting audits for compliance. This is a good way to demonstrate conformance to those operating rules. And then, of course, we really invite you to engage with us as a core participating organizations. Our work group calls are a great way to hear from your colleagues, understand some of the challenges and solutions they have identified in these areas of focus. And then on the next slide, I just want to highlight some of the work that we are doing through the CAQH index. Next year will be our 10th annual report. This report tracks industry progress moving towards fully electronic transactions. There is still a lot of opportunity to eliminate costs. As I mentioned at the beginning of the call, there is actually a $9.8 billion opportunity due to the high volume of eligibility and benefit transactions. And then the index tracks progress. So data collection is underway. There is an email address here if you're interested in how to participate in this year's data collection efforts. We are looking for both plans and providers to submit data. And of course, we try to make it as easy as possible for you to do that. So now we have, I believe, a polling question. I'm going to turn it over to Daphne to conduct the polling question.
Thanks, Erin. So as part of our ongoing commitment to these education sessions, we want to know what topic would be of most interest for the next webinar in our series. So we have a few options up on the screen: panel discussion on the 270, 271, more technical webinar on the 278, and then a webinar series on the 837. So I'll leave this open for a few more seconds. And I also do want to plug our previous webinars. We have a beginning webinar, more advanced webinar, and a panel discussion on the 835. And there's also an introductory webinar to the 278 on our website. And that's a great resource for anyone who's starting to learn about these transactions. So with that, I will close our poll and kickstart our Q&A question with a question for Erin on the eligibility operating rule updates. So CORE plans to submit these rules to NCVHS. So can you share what that means for industry and how exactly that aligns with core certification.
Absolutely. So as I mentioned, CORE updated the eligibility and benefits, data content, and infrastructure rules at the beginning of this year. From a certification perspective, that means that organizations beginning 2 years from the time a new rule set is approved or a rule set is updated, that will become part of the certification program. So organizations going through recertification beginning in 2 years or new certification will need to comply with these updated operating rule requirements. Additionally, the CAQH Core Board submitted the updated eligibility and benefit operating rules to the National Committee on Vital and Health Statistics, which is an advisory body to HHS, for consideration for federal mandate. So the board and our participants believe that these updates are really important and add a lot of value to the eligibility transaction. I mean, thinking about knowing if prior auth is required, knowing if telemedicine services are covered, these are really critical bits of information that it would be much easier not to have to pick up the phone to get the answer for. NCVHS, the process will be that NCVHS holds a hearing or a meeting with the industry where they get feedback from industry participants on the value of the proposed operating rules, and then they will make a recommendation to the Secretary of HHS on whether or not they should move forward with regulation related to mandated operating rules. And Donna, I don't know if you want to add anything or Michelle, related to the work that X12 is doing on updating its standards as well.
Well, I can quickly jump in before Michelle would like to. You made mention of some of the enhanced operating rule requirements that, for those who may or may not know, a lot of what we've been building out for the next version of the published 270, 271 will be a lot more granular in nature. And with that, the operating rules, the new ones that CAQH and the member organizations have worked on and approved, really is a nice stepping forward to some of that newer functionality that can be supported today that will bridge some of that gap that we've recognized from a CAQH core standpoint is a much needed ask by the industry. And when we baby step our way through the operating rules, the way they're laid out now, we will have already been able to meet the pinch point of some of those new ads that we're gonna hopefully have available in that next round of the 270, 271. So I'm very much looking forward to seeing NCVHS recommend the new operating rules to make sure that we can get that little baby step forward and then start seeing some of the ROI instantly.
Thank you both. So before we wrap up here, I want to get in a couple more questions. So in what way do you find that these standards promote innovation? And I'll tie it in with another question about how X12 and HL7 align or harmonize.
I can speak to some of the innovation. Naturally, folks who think of EDI, I think there's a misnomer in the industry that it is an older way of using technology, when really all it is it's a bunch of specifications. The technology that's behind it all is really up to each organization and how they implement that technology to support this. But these are data and format driven requirements. So it helps level set and make sure that everyone is talking in the same language, so to speak, to make sure that there aren't fewer and fewer surprises when it comes to who's doing what. It also made it, between 4010 and 5010, the major change between 4010 and 5010 was, instead of just saying, yes, this is a person who has eligibility and coverage with a health plan, or no, they don't, we've built onto that a natural set of requirements that where you have to support certain answers to the questions. And then with operating rules, they went several steps beyond that to say the questions, payers have to support a myriad of questions, not just a simple, is this person covered or not, which helped streamline some of those industry questions that come from providers to payers. So the innovation is really, from a technology standpoint, is besides the point, because the data derives, the derivatives of the data is what really drives the need to move from point A to point B. So the innovation from a development standpoint is different than, say, the innovation from a business need standpoint. And one has to start before the other one can join in. So we need the industry, we need stakeholders, we need member organizations of X12, member organizations of CAQH, core, we need participants that participate in the WEDI forums. We need them to start helping us understand what the evolution is of their healthcare landscape, so we can start addressing them and building them in to be supportable within the transactions. And that's not just the 270, 271 we're talking about. We're talking about all of the transactions, not just the HIPAA mandated ones, because that's the only way we're going to know what the next landscape or what it's going to look like, is to have input from those who are working in those industries. I'll give an example quickly. There was a question that was submitted, I think, upon registration about the support of the dental procedure codes. The dental procedure codes are supported in the 270, 271. In the EQ02, there is a code set that kind of goes with that external code set reference that I made earlier. The external code set for the dental code, the CDT codes, those are supportable, but the gap here isn't that they can't be supported, it's that payers aren't really, and providers may not be ready to support procedure codes. So CAQH core operating rules will be now requiring a handful of procedure codes be supported, and that is getting us a little farther down the granular conversation, inching us to future versions of the HIPAA mandates, and that helps get those participants who have been asking for procedure code support to be built in to the exchange, to the workflow. And again, that's not so much technology. So if we're talking innovation in a technology sense, that's regardless of the technology. It's the data and the business needs that have to be innovative. And that means those who are coming to the table have to understand what that means to support procedure codes and what it means for them and their business.
Well, thanks so much to everyone for joining us today. We appreciate you spending the time with us. As always, feel free to follow up with us offline if your question didn't get answered. And you can always reach us at the contact information on the screen. And thanks again to our friends at X12 for joining us today and taking the time. Have a great afternoon.
Thank you for hosting.
Thank you.